For those of you who were not here yesterday, I sent the recording to you today via email, and I did not put it on the YouTube channel because I had showed two videos in that session. And unfortunately, YouTube, if you do a session and then you play a video that is for someone else or that came from someone else, it tries to, they kind of block it. And because I have, I got about 15,000 subscribers on my YouTube channel, I cannot risk them blocking my channel. So that's why that link, today's session will be back via the YouTube channel. All right, so yesterday when we left off, we were talking about the CMS 1500 claim form. And the CMS 1500 claim form is the claim form for professional services. Professional services are the provider. So the physician, the nurse practitioner, those billable providers. And that form that we looked at yesterday, it had 33 blocks. And I have to say this carefully because it can be confusing. So blocks. And the form that we're going to look at today is the, well, let me give you a couple of names. The government name is the CMS 1450. So the form we looked at yesterday, let me put this in the chat so that you guys have both the names. So the CMS 1500, that's the form we saw yesterday. And today we have the CMS 1450. So the 1450 is known on the street or in the industry, and I'm going to type this in the chat as well, is the UB04. And this is the claim that the facilities use. They call it the institutional form. So I'm not going to spend a lot of time on this form because from an NHA perspective, they want you to know the difference between the two and what they're used for. And the first one, they expect you to know a little bit more detail. So let me set the stage to this form. So I want you to think of a patient who's in the emergency room. And if you go to the emergency room, chances are you are not going to see an emergency room physician that is employed by that hospital. Now, I don't know if anybody, and I'm not talking about like some of the public hospitals, a lot of those physicians are employed because, well, one or two reasons. One, and I can say this from having worked at, Chicago's major public hospital. One, if you go work at like a Cook County as a hospital, as someone who's fresh out of school, the government will forgive your student loans. So that's one reason that some providers go there. And another reason is that they want to work with the population of patients that they serve. So, but if you branch away from like a Cook County hospital and you look at some of the other hospitals, you'll find that the hospitals don't have an emergency room physician on staff. They actually contract with emergency room doctor groups, and they come in and see patients. And then what happens, those doctors their billing department sends out the CMS 1500 claim form. That was the form that we saw yesterday. And then the hospital, they're going to send out the claim form, the UB04 CMS 1450, for the use of their facility. Now, just out of curiosity, has anyone ever gone to the emergency room and noticed the sign on the wall that says these physicians are not employees of the hospital? Anybody by chance ever see that before?
No.
Okay.
I
So
did at Northwestern once.
yeah, okay. So next time, I know when you go to the emergency room, you're sick, but start paying more attention to what you see on the walls and what's actually happening. So these hospitals can't not technically afford to employ all of these emergency room physicians. So these emergency medical groups, they go around to different hospitals and they actually see the different patients. And they bill for those services from their little group. Whereas this form here is for the facility where the patient is being seen at. Now, I'm going to ask you a question. Who do you think gets paid more money, the professional or the facility?
The facility.
Yes, because why?
The facility is like the middleman. If it wasn't for the facility, you couldn't have the doctor. So I guess they would get paid that plus like middlemaning him out to you or something of that nature.
So not necessarily the middleman. Think
I don't
about it.
know what to call it. Sorry.
Yeah. So think about it like this. The hospital has this big old building, and then they have all of the equipment and they have all the supplies, but they have something even bigger as an expense. And what expense does the hospital have?
Overhead.
Yeah, people. So payroll, salaries and payroll reflect the largest portion of a organization's expenses. So for example, I have people that are working for me, and I'm currently in a physical office space, and the dollar amount that I pay for office space is way less than I have to pay people to do the work. So salaries, benefits, biggest expense. So if you think about it, who are some of the people that, if you go to the emergency room, think about from the time you hit that front door, what types of professionals are you going to see?
Patient intake representative, a nurse, maybe 3 nurses, maybe 2 doctors, a specialist, maybe the lab people.
Let me narrow this question down a little bit. Take the doctors out of the picture because the doctors are not going to be paid by the hospital. So think about all of the people that the hospital has to pay from the time you enter that front door. And y'all forgot somebody who is sitting in front of most hospitals.
Yeah, the security officer.
Yeah, they got to pay them. So security, patient access, that's the person that's registering you. Then you got that triage nurse. That triage nurse may be working with a technician. Then when you go into the back, you got that nurse in the back. You got a technician that's working with that nurse. Then you got all of these different departments. If the patient needs some blood work, here comes the lab. The patient needs an x-ray, here comes the x-ray department. The patient needs the room clean before and after. There's a person that does that. The patient's going to be admitted and they need to go from downstairs to upstairs. Somebody has to do that. So when you look at all of those expenses, that makes sense as to why the facility gets paid more than the actual professional. So very briefly, for the UB04 claim form, what you need to know is that it's divided in a similar fashion from the claim form that we looked at yesterday. except it's a lot more stuff. The claim form we looked at yesterday has a total of 33 blocks on that form. This particular form, instead of calling these little boxes blocks, they call them form locators. So with the form locators on this particular form, there are 81 little boxes. And just like the other form that we saw yesterday, it's not that all of the boxes are being used. It's really going to depend on the payer that we're sending the claim form to and what they actually are going to require. So on this particular form, we are going to have information about the provider. So the name and the address of the billing provider. If you look in the, and let me just get my little pencil out here. Over here, 1 and 2, if you look here, this is where they're going to put the name and address for the billing provider, the provider meaning the facility, where the check should go. That's very important. The facility's ID number that basically tells the payer that it is this particular ID. We have to have the patient's account number. So let me just circle right here. There's 2 little boxes. The first one here is the patient control number. That's the number that we use to identify the patient for that particular date of service, which is different than the medical record number. Reason being is that patients can have multiple encounters, and we need to be able to differentiate between a visit from last month versus a visit from last week, because those are typically going to be separate claims that are going to go out. And so when we are following up on the claim, we need to know what date of service we are looking at. So the medical record number, that's that number that does not change, whereas the account number is going to change per visit. Another area is the type of bill. Is this an inpatient hospital stay? Is it an outpatient hospital visit? Is it an emergency department? Then we have, of course, the tax ID number, and something I want to just reiterate. A lot of this information is put in the system when it's set up. It's not necessarily something that is captured at the right when the claim is going to go out, because it's captured up front. So the federal tax ID number is going to populate into the system. Also, what time period is covered, the from and through. So if they just came in for emergency room visit, the from and through is going to be today. Let's see. Another portion of this claim form, just like the other one, information about the patient. So the demographics that we talked about previously: name, address, date of birth, when they were admitted, how were they admitted? Was it like, did they come in via an ambulance, or did they come in via a private vehicle? Other parts. If the person has an accident, we're going to capture that data as well. And the rest of it is similar to what we saw on the other form, where you have different codes that are used. So let me share a different screen, because I want to show you part of a completed form, because I just think it is better when you can see and hear the concepts. So just give me a second to get that claim form up. And this is just a portion of it, but I want you to just see what it looks like. Almost there, guys. All right. All right, so here is an example of the top half of the UB04 claim form. So I mentioned, the demographic information, all of that. But when you get to the middle of this form, I'm gonna go right here. Besides my RHIA, what type of codes are these codes that are sitting right here?
It says HP. I can't really read it, but HP PS codes.
So yes and no. So one of the things that I think is important for you to recognize is previously we talked about the different code sets and what they look like. So let me just pull up 1 second. Let me pull up a whiteboard and just capture this. So CPT codes.
Yeah.
How many characters are the CPT codes?
5.
They are 5 and they are numeric. I'm trying to type on the screen. Okay, then we have HCPCS codes. And how many characters are the HCPCS codes?
Let's see. And the HCPCS code.
They are 5 as well, but there's a difference between the format of the HCPCS code versus the CPT codes.
Starts with the
It's
letter.
Yes, they are alphanumeric. So the first letter is, the first character is a letter. All right, so then we have the ICD system. And ICD is divided into 2 parts. We have ICD-10 CM and we have ICD-10 PCS. So one of the things that you will want to remember is that ICD-10 PCS is only used for inpatient. How many characters do we have on the ICD-10 PCS code?
7 characters.
7 characters, 100% of the time. Then the PCS codes can start with a letter or a number, but of note, for ICD-10 PCS, the letter O and the letter I are not used so that they are not confused with the number 0 and the number 1. All right, let's see here. Then we have ICD-10 CM. How many characters are the ICD-10 CM codes?
Six.
So they're anywhere from 3 to 7. And there's something else that ICD-10 CM codes have as a distinguishing characteristic. And I'm gonna type one on the screen here. Anybody notice something with the diagnosis code?
Adjustment.
Yes, so that is a distinguishing characteristic of the ICD-10 CM code, but also the ICD-10 CM code also starts with a letter. So then what's the difference between ICD-10 CM and then HCPCS?
The decimal.
Anybody else with thoughts besides the decimal?
So what was the question again?
What's the difference between ICD-10 CM and HCPCS?
Well, between ICD-10 and HCPCS is the digits. It's 5 for HCPCS and anywhere from 3 to 7 with ICD-10. Also the decimal point.
Well,
And-
one is a diagnosis one, and one
Yes.
is I want somebody else to answer it because I don't want to keep answering.
Yes, so I will just review this again. CPT
Okay.
is what they did. CPT is what they did. ICD-10 CM is why they did it. So remember yesterday, we had a patient that had an office visit, and I showed you the office visit code, the x-ray, the urinalysis, and how we had to map the urinalysis with the correct service. So CPT, what they did, ICD-10 CM, why they did it, and then HCPCS is what they actually used. Got it?
Yeah.
And this is on the recording that we had from last week sometime. So now these are, now you know that these are CPT codes. Okay, so other than that, those are some of the major things that you need to know about that claim form. And we have just officially finished domain 4. So again, I highly recommend that you start to watch those recordings, because what you're going to find is that there's a lot of information that we're covering, and we're going from, you know, one domain to the next. And as we're going from one domain to the next, we are tackling one topic at a time. But the cool thing is our next chapter, you're going to say, wait a minute, I feel like we covered all of that or a lot of it. So it'll be a good chance for you to determine if you remember certain things. And so just give me a second, and while I'm getting it loaded, I'm going to actually start to talk. So our next area is going to focus on patient education. And when I talked about the emergency department, the other thing that hopefully you all know and you are seeing at the emergency department is that patients have rights. People don't really realize that patients have rights, right? We have the right to be treated fairly. We have the right to quality care. And so President Clinton in 1998 came up with ways to ensure that patients are being treated fairly, equitably. And so he created the Patient Bill of Rights. So now this is probably not something that you are going to, memorize, but you just need to be familiar with the fact that we have them and why. So when we talk about the Patient Bill of Rights, there are 8 main areas. So number one, we have the right to be given information that we can understand. So if we have a population of patients that are speaking Spanish, we need to make sure that we have information that is in Spanish to help that person be able to understand what care was being provided and why and all of that. Patients also have the right to choose their providers. Now, I'm kind of torn about this because I think in some instances we are boxed into what providers are available. So for example, if you have an HMO and it's with Aetna, you may have access to a certain number of providers, which is different than if you had another payer like Cigna or Humana. Patients have access to emergency services. So there was a federal law called EMTALA, and EMTALA basically says that patients cannot be turned away because of their inability to pay, and that hospital has to stabilize them before they are discharged or sent to another hospital. Patient has the right to participate in their care. Like, patients shouldn't just be told this is what's going to happen. They should understand and be able to participate and ask questions. It goes without saying, but it's unfortunate, but we have the right to be respected and that we are not discriminated against. Additionally, we have the right that our information can be confidential and that we can file a complaint. We can appeal decisions if we want to, or if we feel that it is necessary. So for example, patients can request that components of their medical record be revised. Now, that doesn't mean that it's going to happen, but you can make your issue known to the provider and then explain why you believe it needs to be updated. So I saw in a medical record previously where the doctor stated, patient states that they do not have this condition and that it is incorrect based on other providers that they have seen. It was noted, but they didn't do anything about it. But patients have the right to make that known. And then as it relates to us as consumers, we have to make sure that we understand the healthcare system and what can and cannot be done. And I think this is something that needs to be we need to be better educated about, because I think we often are not given the information in a manner that we can understand. A lot of people, when they sign up for health insurance, they just say, okay, I got insurance, but they don't read the fine print. One of my friends, she tickled me yesterday because she said her son, because he's going to get a summer job, he's 15, he decided to go ahead and get the COVID vaccine. And so he said he was sitting there reading all 6 pages of the COVID vaccine paperwork and was asking questions. She said she was just sitting there like so proud of him, because he was just like, first of all, he thought he was going to turn into a zombie. And so he was like, you're not just going to stick this in me without providing me with some education on side effects and all of that. So I thought that was pretty cool. I feel like the younger generation is more vocal, and as compared to my grandparents, like whatever the doctor said, it goes. So we do have to explain the patient bill of rights in one shape, form, or fashion, such as posting notices on the wall. In the emergency department, you'll oftentimes see that they will post the patient bill of rights, or they'll post it on the website. They'll post it somewhere so that patients know that they have rights. But then also, we talked about this before, if patients have the right to participate in their care, and the expectation is that they follow the doctor's guidance and that they agree on it. But sometimes we have patients that they just do what they want to do. And so there are some situations where we may have to withdraw our services from that patient. So basically, we're going to fire the patient. We talked about this before. We have to give the patient a letter in writing. We have to let them know that they can get a copy of their medical records. When we send out the letter, we want to do a certified mail so we can get confirmation that the patient actually received it. And that is all for that part. So I want to talk a little bit about the Affordable Care Act. Has anyone looked into the Affordable Care Act, and what did you discover?
I did, but it was a long while ago. So I think most of it has been changed, hasn't it? Like they've upped their policies or something of that nature. So like when it first began, it was pretty affordable, and then I think over time it started, like the cost started amping up. But I don't know if it's, yeah.
The insurance companies was trying to make a profit.
Yeah.
So here on the screen, what you see is I went into the marketplace and put in a fake age, not mine. And I wanted to find out what type of plans the marketplace would offer to me. So I put in somebody who's 35 and healthy, and they don't smoke. And so this is what came out for me. So they gave me 3 options: bronze, silver, and gold. For these 3 options, the first thing that they tell you is what the premium is per month. And as you all should know at this point, the premium is what you pay to get the plan, as well as what you have to pay monthly to keep it going. So when you work for an employer, your employer pays a portion and you pay the other portion. Your employer generally pays a larger portion, or they could pay half. So the computer said, this is the premium for the bronze average, and then the gold. But based on the plan that you select, that's also going to determine what your deductible is, as well as what your copay, co-insurance, all of those other out-of-pocket costs that you have to pay. And so I think a lot of times people think, oh, I'm going to go with the cheaper option, not realizing that, yeah, the premium may be cheaper, but you have this high deductible. And so with the high deductible, that means that the insurance company doesn't pay until the patient has met their deductible for the year. So I think I mentioned to you that my deductible is $1,200 a month for, not a month, a year for my insurance. And typically I don't use $1,200 worth of services. And so what that means is my insurance company doesn't pay. I'm continuing to pay. But if I met that deductible, then they would kick in and pay a portion. Years ago, we used to see in the grass, like health insurance, $89. And when I used to see that, I used to just get really upset, because I'm like, why are they lying to people, telling them that, you got this health insurance for $89? Because those plans, most of the time, this was before Obamacare, Affordable Care Act, most of the time, those policies had a $5,000 deductible. So yeah, you got insurance, you got an insurance card, but you got a $500 deductible that you have to meet. And then on top of that, a lot of the things that you thought would be covered aren't covered. So that presents a problem, because now you're still, unfortunately, having to pay a lot out of pocket. And so that's why some of the younger generation, they're just like, I'll just chance it without having the insurance. I'm not going to worry about, I'm just not going to worry about having insurance, and I'll deal with it when it happens. All right, so the next part of patient education is about consent. And we actually talked about this briefly last week. So there are several types of consent. The three that you should be familiar with are implied, verbal, and informed. Implied is like when you go to get a COVID vaccine. If you take your arm out of your sweater and turn your arm towards the nurse, it is implied that you are consenting to the vaccine. Because if you weren't, you would still be sitting there bottled up with your coat on or whatever, and until they say something to you. But once they say, okay, we're going to give you your COVID vaccine in the left arm, once you take that left arm out and get in position, you are consenting to that service. All right, then we have verbal consent. That's when you actually say verbally that, yes, I want the vaccine. Then we have informed consent. That's where you sign a form. That is generally before you get like a surgery or something where they're going to tell you about the risks, the benefits, all of that, and then you are able to ask questions. And so that's the one where they say, you know, you could die as a result of this service. Then we have minors. Anybody have any minor children in your household?
Yep, my grandson.
Yes.
Of course.
Yes, I have an 11-year-old.
All right. So whenever a minor needs a surgery or some type of treatment, consent must be obtained from the parent or the guardian, except in those situations when it is an emergency. Now, of course, there's all these other factors that come into play. If you have a patient or a child who is a minor who is living with one parent, it's also going to take into consideration who is what is known as the custodial parent. Now, if the child is visiting the non-custodial parent, that means who has custody, consent can come from that parent, because if they're at dad's house for the weekend, the dad has temporary custody for the weekend per their paperwork. We also have situations where minors are like, yeah, I don't want to listen to you anymore. And I'm going to emancipate myself. And there are several ways a minor can become emancipated. They can get married, they can go to the military, they could move out, support themselves, they can emancipate themselves from their parents, and they can give consent. Then there's also the situation where somebody is pregnant. If somebody is pregnant, they can make their own decisions. But then once they're not pregnant, if they're like under 18, they got to go back to getting the parents' consent, which is weird. One thing that you will see from this program is we talk a lot about rules, but when you get into the real world, some of those rules differ. Also, this is a national test, so that it does not take into consideration situations where people are, or where a state has a particular rule that we have to follow as opposed to the federal government. And when we have situations where we have state and federal laws, we are always going to follow the law that is the strictest. So if Medicare says we have to keep records for 5 years, but the state of Illinois says we have to keep records for 7 years, we're going to follow the state of Illinois' requirements. All right. So back to some concepts that you know about, and I'm going to ask for audience participation. What is a premium? And I just said this answer, so you
But that's what you got to pay in order to get and keep your insurance.
This is what you have to pay to get that policy going. All right. And then what is the deductible? Thoughts, somebody, the deductible?
The deductible is when you, how much you got to pay into it before the insurance starts covering it. So if you have a $5,000 deductible, you can get tests, blah, blah, blah. You got to pay all that until you hit that deductible, and then the insurance pays for you.
Absolutely. Okay. What's the difference between co-payment and co-insurance?
Okay, so the
Co-payment,
co-payment,
well, okay.
well, the co-payment is a small fixed amount, but the co-insurance, that's the percentage that the patient pays after the deductible is paid.
And it can vary based on the insurance. All right. So for example, Medicare Part B, they have this 80-20 rule. So Medicare pays 80% of what they allow, and then the patient pays 20%. But you can have some plans, and these are questions that people need to ask when they're getting policies. If it has a co-insurance, well, how much do you pay? So for example, my insurance, if I have surgery, major surgery, they pay 90%, I pay 10%. But guess what else I pay? I pay a higher premium so that in the event that I need to have surgery, I'm not having to pay a large amount out of pocket. All right, so here is an example of an explanation of benefits. And let me give you the abbreviation. We call it the EOB. And with the EOB, usually it tells the patient, this is not a bill. But even though we told the patient, this is not a bill, or it tells the patient, this is not a bill, what do you think the patient does when they call us on the phone?
It's a bill.
Exactly. And you're like, it says it right there at the bottom. This is not a bill. But what this is a form letter that comes out nowadays. To save paper, they're doing it quarterly. So any visits that you've had in a quarterly time period, they'll have all of the charges there or what they've paid there. So usually what happens is it has the date of service, how much the provider charged. Then they have a column called network savings. Now, network savings is like a discount. And what do I mean by that? Nobody pays us, for the most part, what we charge. We have contracts with these different payers, and they pay us, what we agree upon. And so we agree, even though we charge 100, we will accept a certain dollar amount. So in this particular case, there were some network savings, but they did not pay anything. And what it could be in this situation, and this is just a small snippet, and I have some more examples that we'll look at. What could be in this situation is this is something that they don't cover, or another insurance company has already paid in those cases where the patient has more than one plan. But this particular form here is called an EOB, or explanation of benefits. Now, here's another example, and I like this one because the words are even bigger. This is not a bill. So on this particular one, what we see right, let me get my little pointer, right here is the CPT code. And this is what we charged, $135. This is how much is covered. And then look at how much they paid. And then a little further down here, you'll see that this patient has $1,000 deductible, and then they have a $1,500 per member co-insurance. So what they're saying here, apparently this person has not met their deductible, and so that's why they have to pay this whole $75. So one thing about deductibles is when the claim gets to that payer, they're telling us what the patient has paid based on the claims that have been sent in. So sometimes patients will say, well, I've been to the doctor, I've already met my deductible. Well, the challenge is if that clinic or hospital hasn't sent in that claim, the insurance company does not have on file that the person has met their deductible because they haven't received the claim yet. And there are a lot of factors that go into when that claim is sent to them. It could be days, weeks, or it can even be months. Here is another example, and now I'm going to ask you all a question. Look at where it says number 2, and please tell me what these 3 codes are. What type of codes are these?
CPT code.
The first one is yes. Second one?
Another CPT code
And then the third one?
will be a HCPCS code.
And a HCPCS code. Thank you, thank you, thank you. All righty. So then next up, we have another one. And here again, you know, they all got a lot of the same information, but it's just for different payers, different patients, all of that. So you'll notice on here, they basically are telling us what each and every service, what they covered, what they didn't cover. And let me just call out one particular area. Here, they have the CARC remark codes. Those are universal codes that go on all of the claim forms that lets the provider know why they did not pay for something. So for example, CO45 is contractual obligation, meaning that the patient is, that the doctor agrees to write that dollar amount off. And so again, if the doctor is participating in a particular plan, they agree to accept what the provider or what the insurance company gives as payment in full. So what they charge is not what they get paid. So if you look at this one, we charged $182. They allow $150. $31.08 is a contractual obligation. The patient pays $40. The total dollar amount is $110.92. Now, you may be thinking, why do I need to know this? Well, what if the insurance company sends you the information and it is incorrect? You need to be able to let them know that, hey, this is not our contractual obligation. Now, the last ones that you saw were called explanation of benefits. What you're looking at here is called a remittance advice. And a remittance advice is what they send to us, the facility or the provider. The patient gets the explanation of benefits and we get the remittance advice. To help you visualize or conceptualize the remittance advice, think of it like a check stub because it shows us all the patients that we have submitted claims for and what they have paid or did not pay. So for example, the first patient has the 811020 CPT code, 950 CPT code, 99205. So all of these different CPT codes. And then to the right of them, you will see the amount that was billed, the amount that was approved, the amount was paid, amount that went to deductible, the amount that went to co-insurance. There's a situation where they're saying this service was actually bundled into the other service. And what bundled mean is, we're not paying you for both of these services. We're only going to pay you for one. So in this particular situation, that's an office visit and removal of the earwax. And they're like, yeah, we're just paying you for removal of the earwax. We're not paying you for the office visit. Then you see a bunch of more CPT codes and how they paid us. So what happens is this check gets deposited into our system, and then we apply the payments to the different patients' accounts to then say, okay, their account balance is 0, or our account balance is 0, or the patient owes us some money and now we need to send them a statement. All right, so let's talk about Medicare. Medicare is the largest payer of healthcare in the United States. And why are they the largest payer of healthcare in the United States? Well, number one, they cover individuals that are 65 years of age or older, but they also cover people who are younger than 65, who have certain disabilities, as well as people who have end-stage renal disease. The Medicare program is divided into 4 parts. Part A is for hospital insurance. Now, generally, once you become eligible for Medicare, you can get this Part A free of charge if you are eligible for Medicare. So they cover inpatient hospital visits, nursing facility visits, some home health care services. They cover some hospice services. And the way that they pay for these services, Medicare always has a little catch, but they pay for them based on what is known as a benefit period. And Medicare has all kinds of rules about what they will and will not pay. Now, not free of charge is Part B. Part B is for, they call it voluntary supplemental insurance, but it really covers like medical visits, some labs, some supplies that are not covered by Part A. And it covers like x-rays, but it does not cover medications. So Part A and Part B, we call that the original Medicare plan. And with this original Medicare plan, people were like, man, I really need medications. So HMOs, health maintenance organizations, were becoming very popular. And so the government said, hey, let's get into the HMO business. And so they came up with Medicare Part C. Medicare Part C is the insurance that covers Part A, Part B, but it also covers prescription drugs. They call it today Medicare Advantage. So just like you would have like Humana, you would have Blue Cross Blue Shield, Medicare has those types of programs available to their beneficiaries. Then we have Medicare Part D, because some people said, you know what, I'm not getting that Medicare Part C. Oh, here's the other thing about Medicare Part C. Medicare Part C, you now have a primary care physician. Well, some patients were like, I don't want to have a primary care physician where I'm limited to where I can go. So some patients were like, yeah, I'm going to just stick with the original Medicare Part A and B. But then there was still this issue about not having any prescription drug coverage. So in 2003, I think it was, the government came out with Medicare Part D, which is for prescription drug coverage. So this is another plan who involves some of those insurance companies. And earlier someone mentioned how you looked at the Affordable Care Act plans and how the plans got higher and higher. Well, all these HMOs and all those Humana, Blue Cross Blue Shield, they were like, yeah, Medicare, we'll get in on this prescription Part D coverage, but there is a fee associated with it. So you will see a lot of people who are Medicare age, who unfortunately don't have enough money to pay for prescription drugs, let alone pay for their day-to-day bills. And so what winds up happening is that they wind up getting a job at like Walmart or Target or some type of part-time job so that they can get benefits. So that's Medicare. Then Medicare says, you know, there are some times where the patient is going to receive a service that they may not cover in that particular instance. So, for example, Medicare pays for, you know, hospice services, they pay for home health agency services, but they don't cover it for everybody in every situation. So there are times where we believe, Medicare may not pay for that service. In those situations, we give the patient before, emphasis on before the service is rendered, an advance beneficiary notice. In this advance beneficiary notice, we are telling the patient, hey patient, Medicare may not pay for CPT code, blah, 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 blah. That's what we would enter in letter D. And it says, we expect Medicare may not pay for D, whatever that CPT code. Then in D, we have to give the CPT code again, the description, and then we also have to tell the patient why we believe Medicare will not pay and what the cost is. At this point, patient has 3 choices. Choice number 1, they can get D, and the provider can say, pay me now. And when the Medicare summary notice comes in the mail, the patient understands that they will pay for it. Let me pause and tell you what a Medicare summary notice is. It is the same thing as the EOB. It's just Medicare's version of the EOB. So option 1, you can get it. We'll bill Medicare. They don't pay, you pay us. Option 2, you want D, but don't bill Medicare. And we're going to collect payment now. And they cannot appeal if Medicare is not billed. So this is basically letting the patient make a decision up front on how they want to proceed. And then option 3, I don't want the service and I understand that I am not responsible. I cannot appeal to see if Medicare is going to pay. So we have to give it to the patient in advance. That's why it's called an advance beneficiary notice. Some organizations, I don't know why they do this, but they'll do a blanket ABN. And what it means is when we need it, we can pull it out. But Medicare says you can't do that because you can't have the patient sign a form for something that would happen later, basically saying anything and everything I have that Medicare may not pay for, I've signed this form. Also, you can't say, oops, we did the service. We didn't give the patient the option to make a decision. So now, let's mail this form to the patient. Can't do that. It has to be given to the patient in advance. If we don't give this form to the patient in advance and Medicare does not pay for the service, we cannot bill the patient for the service. When Medicare sends the patient their Medicare summary notice, they will tell the patient, you are not responsible for this. All right, so here is a little snippet of the Medicare summary notice. And it starts off with one of my favorite things, which is, this is not a bill. But it also tells the patient how much of their deductible they have met. And that again is important. Now, Medicare Part B deductible is going to vary based upon how much the person has made. And so they have the kind of like the lower tier of what a patient can pay. And if the patient made more prior to getting their Medicare, it could be a little higher. Additionally, Medicare will also tell the patient which services were denied. And they will tell them you may be billed $90.15. Now, the reason that they are saying you may be billed $90.15 is because on our CMS 1500 claim form, we have listed CPT modifier GA. GA is attached to the CPT code to let Medicare know, hey, Medicare, we have assigned ABN on file, and we're letting you know we have it on file, and that's why they're telling the patient that they may be billed for that service. And they say may be billed because we might have collected the money up front. All right, here's the second part of, well, actually the Medicare summary notice can be like 6 pages, but I just carved out a couple of pages. So first up, you will notice we have CPT codes again. And for the first one, which is the eye exam, Medicare's like, cool, we approve $107. Notice nobody is paying us what we charge. So Medicare, for Medicare Part B, which is what these services are, Medicare pays 80%, the patient pays 20%. Now for this second service, Medicare was like, nope, we're not paying for this. Now, I suspect in this particular scenario, Medicare didn't pay for the service because it was not medically necessary. And Medicare, and actually no insurance for that matter, pays for services that are not medically necessary. So you can't say we did a chest x-ray and the diagnosis code of a urinary tract infection, because the insurance company is going to say, no, those two don't necessarily go together. All right, so that's Medicare. Then we have Medicaid. Medicaid patients are individuals that have a medical need, or they are what are known as categorically needy. And categorically means that they fall into certain categories. So it could be someone who is pregnant and their family income is below the federal poverty line. We can have infants that are born to somebody that's on Medicaid, they would be eligible. Individuals who are disabled. So for example, my daughter, she's 29, but mentally and physically, she will never, ever be able to work. And so she is categorically needy for Medicaid, but she's also medically needy for Medicaid. However, because I cover her on my private health insurance, Medicaid is her secondary payer, because remember, government programs are always going to be the payer of last resort. All right, other things about Medicaid. So Medicaid is ran by the states, but they receive funding from the federal government, partial funding. And because the government gives partial funding, they mandate what services must be covered. And then the state can decide that they're going to cover some other things. So for example, years ago, people would say, oh, I'm going to leave Illinois, I'm going to go to Wisconsin, or they're going to go to Minnesota because the Medicaid benefits were better than they were here in Illinois. Now, outside of the medically needy, the categorically needy, the services covered, the other thing that you need to know is Medicaid has also got into the HMO business. And the one point that I want to make sure is very clear to you, when the patient has an HMO, that means they are assigned a primary care physician. With the primary care physician, that means that they must go to that particular doctor for all of their needs. And if they need to go see a specialist, the primary care physician, also known as the gatekeeper, says yay or nay in terms of if they can go and see a specialist. So that's one of the reasons that people don't like HMOs, because of the fact that you can't go where you want to go. So Medicare got into HMOs, Medicaid got into HMOs. Actually, all of the federal government programs have got into HMOs because it's a way to control costs. So speaking of government programs, the last one, TRICARE. Now, this is probably not something that NHA will ask you about, but I like to discuss it because I believe that you should have at least a basic foundation of all the potential payers that you could see. So we have TRICARE. TRICARE is the program for our military professionals. And TRICARE, too, has managed care options. And they have different plans based on if the patient is overseas, if they're going to go to a military treatment facility. They have so many options. In fact, TRICARE has a website that is dedicated to all of this payer information. Usually in the private setting, you're not going to see too many TRICARE patients unless they are, I don't know, home for the holiday. And even then, most military professionals are going to try to go to a military treatment facility. Number one, because they're gonna have to pay if they go outside of the, military facilities. All right, then we have the commercial insurance. And you've heard me mention HMO over and over and over again. So you should already know, we talked about this before, but I will remind you, with an HMO, everything is controlled by the primary care physician. So let me explain even more why. With the HMO, every patient is assigned, or they sign up for a particular doctor. And when the patient signs up for that particular doctor, what happens is that provider receives, get this, a per member per month fee for having the patient on their list. Yes, you heard me. Per member per month fee, just because the patient is on their list. It doesn't mean that the patient comes in. The fact that that provider is responsible for that patient's care, they receive a capitation payment. So if the doctor has patients from Aetna, Blue Cross Blue Shield, Humana, all of those different commercial insurance payers, they receive a payment per member per month. And this is the cool thing. If the patient never comes in, we get to keep the money. Anybody know why we get to keep the money, even if the patient never comes in during that year?
Probably already paid by the government.
No.
Yeah.
So the reason we get to keep the money is because when that patient signs up as a patient under that particular doctor, the doctor assumes the risk for the care of that patient. So somebody that's young, no health issues, they're not coming in. But guess who's coming in quite frequently? The patients that do have lots of problems. And remember that claim form that I showed you earlier? When you have an HMO and you're getting the capitation payments once a month, we don't file a claim form with the insurance company. because we've already been paid for the service via the capitation payment. Does that make sense? I'm gonna take silence as a yes. Okay. So with HMOs, a lot of services have to be pre-authorized. We talked about pre-authorization before. It is not better to ask for forgiveness. If a service requires pre-authorization, that means that we want to get that service pre-authorized up front. We cannot wait until after the service has been rendered. However, if there is a emergency, we do have some flexibility. Then the opposite, I'm going to say the opposite of a PPO or HMO is a PPO. So with a PPO, the patient does not have to sign up for a primary care physician. They basically pay a higher premium. They have a co-payment, they have co-insurance, they have everything that the HMO has, except they get to decide if they want to go see a specialist, they can just go see a specialist. So depending on how sick that patient is and how much they can afford, some patients will choose a PPO just so that they can have the flexibility to not have to go and get permission. So for example, I have asthma. And as a patient who has asthma, I don't want to go to my primary care physician when I need help with my asthma. And honestly, if I'm having problems with my asthma, my primary care physician is going to say, hey, what the lung specialist say? So when you have a PPO, you have that flexibility. All right. And the last thing that I'm going to cover are testing and procedures. So by now, you should know that when a patient is going to have a test or a procedure, there are some steps that we have to follow. So in some instances, patients can't arrange their own tests. We have to get those tests scheduled for the patient. So when we are setting up an appointment for some type of test at the hospital, the first thing we have to do is get an order from the doctor, and it has to be a written order. Depending on the setup, we may be able to electronically send the order over to the hospital, or we may have to print the order, give it to the patient, and they take it with them to the hospital. Some services require pre-authorization. For example, I needed an MRI of my knee. And my insurance company was like, hey, what's wrong with an x-ray? And the reason they said that is because they didn't want to pay for an MRI because an x-ray is less. So I got the x-ray, the doctor, the the radiologist said, oh, you got a torn meniscus. So then the insurance company was like, the doctor said, I needed surgery. So then the insurance company was like, well, what about physical therapy? That might make the knee better. So I went to physical therapy. Physical therapy did not help it. And so then finally the insurance company approved pre-approved the surgery. So one of the things about pre-approval that is very important is that we need to know up front what the insurance company is going to pay and how much the patient has to pay. So if the patient has a co-insurance, for example, we may be collecting that money up front, and we need to make sure that their plan covers it. So for example, I think I mentioned this before, but I needed to have surgery. And when I arrived at Northwestern for my pre-operative workup, the lady at the front desk, patient access lady, said, all right, this is the surgery that your doctor is going to do. This is how much your insurance company is going to pay. This is how much you are responsible for paying. How will you be making this payment? I'm like, how? No, I knew what she was saying. So basically, I had to pay that dollar amount before they would do my surgery. And so I said, okay, I'll give you some now. And on the day of the surgery, I'll pay the rest. Sure enough, when I came for surgery, they said, we'll take the remaining balance for what you told us you would pay via a Visa. And the reason that they do that, it was an elective surgery. It wasn't something that I needed to have. It was something that I wanted to have. And my doctor agreed that I needed it. But because I wasn't dying, they requested their money up front. And that's how they stay in business. So after all of that pre-authorization business, another reason why it's important. Maybe the doctor says, I want to do the surgery via an open approach. And then maybe the insurance company is like, well, you can't do it where it's closed. Why you got to do it open? Because the closed procedure pays less than an open procedure because it's less invasive. So after we get all of that pre-authorization business taken care of, then we got to figure out the facility. Well, when we get the service pre-authorized, we will also learn what facilities the patient can have that procedure done at. And not all facilities are going to be in that patient's network. So we got to make sure that the patient is available, the facility is available, and then we go through the steps to order that test. Now, when the test has been scheduled, we have to make sure we take care of all of the consent forms. If there are any instructions that we need to give the patient, we will give the patient. We oftentimes ask the patient to repeat the instructions back to us because that is the way that we know that they understood the information that we gave them. So like what time they need to be at the hospital, what they need to bring, all of that good stuff, because we want to make sure that everybody is on the same page, because there's nothing worse than having the patient show up for a service and they are not prepared for that service. So we like to make sure that they understand. So it's kind of like, sometimes when you're having surgery, they'll say no false nails, right? So if somebody has false nails on, they need to get them removed before they have the surgery. Some surgeries, you got to shave before the surgery. You can't wear deodorant, just all different types of rules and regulations. And so the patient needs to know that up front, not eating before the surgery, 8 hours before. So we have to make sure that, remember, we schedule the patient for that slot. And we want to make sure that when it's all said and done, we can actually generate a bill for that service. All right, so that was patient education. And I don't think that title is a good title for that section, but that's what they call it. And hopefully you can see that a lot of the topics that we're talking about, we talk about them in more than one area. And that's because the information does really truly cross over from one section to the next. All right, questions?
No, I don't have any.
No question.
Okay, so some of you did not take the last exam.